Afternoon, everyone, and welcome to the launch of the Patients Deserve Better campaign for Waterford. For those of you familiar with the campaign, this is the fourth in our series of launches. We started the campaign in October last year in Limerick, and we then moved to Cork in November, Galway in December, and now we're very happy to be in Waterford today. We're delighted to have a fantastic lineup of speakers this morning. We have local consultant neurologist Dr. Jed O'Connor, who's going to provide an overview of the service. We have Valerie O'Shea, a local person living with multiple sclerosis. Maura Hayes, the one and only neurology nurse in the Southeast, is going to speak about her role. And finally, we're going to be joined by Tony Wilkinson, who you remember was the patient advocate for our Cork launch and has been very active since then in continuing the Patients Deserve Better campaign in Cork, and is just going to give the organisations attending this morning some ideas of what they have done there working with local elected representatives in Cork. My name is Magdalen Rogers. I'm the Executive Director with the Neurological Alliance of Ireland, which is the national umbrella for over 30 neurological charities. I'm going to speak very briefly, just a few slides just around the campaign and the intentions of the campaign. I want to welcome everyone. We have a very strong attendance at this launch this morning, and particularly to welcome the local representatives. We've had a very strong showing from our local politicians this morning, and I would certainly encourage them to introduce themselves using the chat function. Similarly, if anyone has any questions or comments throughout the morning, this launch will take about 40 to 45 minutes. I'd encourage them to use chat to introduce themselves, to make any comments and ask any questions. And as soon as all of our speakers have finished this morning, I'll address the question to the most appropriate member of the panel. So I'm going to start off before I hand over to Dr. O'Connor. I'm just going to start off with a couple of slides just about the campaign and what we've done to date. So the first slide there just highlights the dramatic shortage that we have in Waterford for specialist neurology nurses. And as I say, the one and only nurse is going to talk this morning about her role and coming on board after so long without a nurse to just have one neurology nursing post in place in the hospital. These are some of the organisations that are supporting our Patients Deserve Better campaign. The campaign is supported by Roche, and it's calling for increased investment in neurology nurses across Ireland. We have a shortfall of over 100 neurology nurses to support adult neurology services in Ireland. And as you can see, the situation in Waterford is quite stark, and that's replicated up and down the country, where the number of neurology nurses in post is completely insufficient to meet the need. Waiting lists in neurology, they were already critical. COVID has pushed them up further. One of the key messages of the campaign is that nurses are critical to tackle those increasing waiting lists and to provide a vital service for people living with neurological conditions. I would encourage people to visit the Patients Deserve Better website, www.patientsdeservebetter.ie, to learn more about the campaign and really to learn more about the role of nurses in supporting people with neurological conditions. I would certainly encourage the elected representatives attending this morning to find out more from our website on the shortages in each region and really what nurses do day to day to support people with neurological conditions and how vital that service is. Again, from our website, the value of nurses, you can see that central diagram of all of the things that they do, not only supporting the neurology services, but just in terms of the wider health service of reducing waiting lists, reducing trolley counts, supporting the neurology service in the hospital and making it much more efficient. I go back to my earlier comment about the shortage of neurology nurses across every neurology service in Dublin, in Ireland. NAI carried out a thorough audit, which we published in March 2021, highlighting the deficits in staffing, but in particular in neurology nurses across the country. That informed our Patients Deserve Better campaign. Many neurology patients in Ireland continue to have no access to a nurse specialist. And I'm just giving the statistic there from the recent mapping exercises carried out by Dr. Suzanne Timmins, a national mapping exercise of Parkinson's services, which showed that 80% of people with Parkinson's disease throughout Ireland don't have access to a nurse specialist. And again, just to encourage people to visit our website, patientsdeservebetter.ie, to find out more about the campaign, and also to learn how they can support that campaign by contacting their local TDs and highlighting the situation in their particular region. So I'm going to pass over now to Dr. O'Connor, because I've just given the national overview very briefly, and Dr. O'Connor and Maura and Valerie will speak in much more detail about the situation in the South East. So if I could hand over to you now, Dr. O'Connor.
No problems, thanks very much for that. So let's see if I can overcome my normal technophobia and start sharing the screen properly. This takes a little while, but hopefully you should all be seeing the screen as we have it. Now,
you can see it there, that's great.
Perfect. So listen, my name is Dr. Jed O'Connor. I'm a consultant neurologist here in the South East, and I suppose my role here is just to try and kind of basically, I suppose, give a rough idea of the service overall as it currently stands, how we're standing, what we can do with it, and I suppose as well the role that nurse specialists may have in terms of trying to improve the service. Now, as those of you who are the elected representatives know, the definition of the Southeast region can vary considerably. And that's no different, actually, in many ways with the patients we have. We've had people referred to the clinic who are coming down from North Tipperary, North Kildare, South Wicklow. And generally, when we talk about it, the area we're expected to cover would be the region about Waterford, Wexford, Kilkenny, Carlow, South Tipperary, the old Southeast Health Board region. Now, because of these variable definitions, the catchment population we're expected to serve can vary quite considerably. And some of this depends on older or pre-existing referral routes. So, for example, for multiple sclerosis, where the service was simply not there until more recently, people often went to places in Cork and Dublin. For epilepsy, however, oftentimes they would do it more locally. So generally, it's accepted that we will need to cover up to 500,000, the needs for up to 500,000 people in the service out of the Neurology Centre here in Waterford. Now, one of the difficulties, of course, is that you can see even from that map that the region crosses different hospital groups. So, for example, Waterford and South Tipperary are allied with the South-South-West group. North Tipperary, which occasionally get patients from, goes into the Midwestern region. Wexford, some of Kilkenny, tends to go to Ireland East, which makes it difficult sometimes to coordinate local issues. So just to move in terms of what neurology does, well, basically as I often describe, when I was asked once this, I said we're the fits, feints and funny turns people. Essentially, we're disorders and diseases of the central and peripheral nervous systems. That's your brain, spinal cord, nerve roots, nerves out of the muscles and the muscles themselves. And when you think about that, that's a vast category of conditions that we have to deal with. It's one of the old medical cliches that there are more sub-diagnoses within the speciality of neurology than there are in the rest of medicine combined, which when you look at this, especially the neuromuscular side of things, really is quite popular. The typical conditions we'd see a lot of, migraine would be one. Really, when you think about migraine, people often think about it's just being a rarity, but it's actually about up to 10% of the population. So we can have nearly 5,000 people in the Southeast region suffering from this. MS, 1 in every 1,000 people in Ireland has this condition. It's the commonest non-traumatic cause of disability in those under the age of 40, and we see an awful lot of that. Epilepsy. Epilepsy affects 0.8 to 0.9% of the population, generally in most Western European countries. So to give you a rough mental picture of what that's like, based on the population of Ireland, that's probably somewhere in the region of about 40, maybe 45,000 people. And the population of Waterford City at the last census was 50,000. So we're talking a decent-sized city worth of people. And to give you an idea of the severity, epilepsy kills about as many people per year in Ireland as melanoma. Outside of those, we have a huge amount of other conditions. So we have the movement disorders, Parkinson's disease, essential tremor, dystonic tremor, PSP, congenital basal syndrome, dementias. We see a lot of young dementia patients, people who don't fit into the age of the medicine for the elderly service. Stroke, probably do that less of that here purely because of advance in our service, but also we know that a lot of neurology services are involved in stroke. Autoimmune conditions like myasthenia gravis, genetic conditions like Huntington's, neuromuscular disorders like motor neuron disease or CIDP, and functional neurological disorders. It used to be someplace.
Excuse me, Jeb, can you do me a favour? You need to move your slides along.
Yeah, no problem.
Yep. Sorry about that.
Well done. Hopefully that the screen sharing should be available at this stage. Let's check to see if it's, unless it's been paused. As I say, it should be okay. Resume the share. Now, as I say, we'll try this one again. Hopefully that should be coming through there now at this stage, I think a little more accurately. No, I think it's still probably coming through. Slideshow. Now, is that coming through there at this stage? No, still not coming. Okay. We'll just have to work around this one, unfortunately. I'll try a new share. Let's try this one. A bit better?
Yeah.
Perfect.
Yeah.
Now, the problem with neurology is we had a reputation as the diagnose and adios specialty. That is, we'd come along, do loads of investigations, tests, examinations, throw out multiple jargon, and then walk away from someone as with no therapies we could try. But really, there have been massive changes in the treatments of this in many conditions in the last 20 years. And I think this is where we need to kind of emphasize how much more we can do for people now. Neurology in the Southeast region is really still a relatively new service. The first consultant neurologist was appointed here in 2007, which makes us only about 14 years old. So if I seem like a moody teenager occasionally on a Monday morning, that's why. Currently, in terms of overall staff, we have about 1.2 whole-time equivalent consultant neurologists and 1 neurology NCHD. Now, to be fair, we have recently interviewed and obtained another consultant neurologist who's waiting to start, and there are negotiations to try and bring the overall consultant numbers up to 3, which would be good for the population we have, but that still leaves 3 consultants, 1 NCHD, and a whole lot of empty space in terms of trying to deal with people. In spite of this, we're still providing a number of services. We do general neurology clinics where we see people with migraine, dementia, motor movement disorder patients are seen in general neurology clinics. I know Dr. Crowley, my colleague, does botulinum toxin and injection clinics for dystonia, migraine, other issues that way. I myself run a first seizure clinic and regular epilepsy clinics. We're doing MS clinics here locally. We have a very busy inpatient consultation service here at UHW. Patients who are admitted under other services, we'll often see them for neurological causes and arrange for investigations and liaison with our colleagues in Cork, Dublin and other centres, and also arrange to see them back in our own clinic. And we do a lot of telephone advice to other hospitals in the region. So Wexford General Hospital, Tipperary University Hospital and St. Luke's of Kilkenny will all often ring for advice, and we'll try and help out there as much as we can within our own limitations. Until a few months ago, we were quite lonely in that we had no other support, but our first neurology nurse specialist was appointed in the second half of 2021, which we're very delighted with. No pressure more. There we go. I suppose in some way to try and explain a little more about the neurology nurse specialist, you'll see these 2 terms, CNS and ANP used. CNS refers to clinical nurse specialist, ANP, advanced nurse practitioner. 2 slightly different practitioners, but we often use the phrase nurse specialist to cover both as a more general term. Similar in many ways to a lot of other services, there's an increasing recognition of the role that the nurse plays. No one at this stage would set up a diabetes service without having a nurse specialist here to help monitor insulin. No one would set up a cancer treatment service without having a nurse specialist to support the patient's counselling. It's no different here. And I think one of the good things about the developments in neurology is that the Neurology Model of Care document in 2016, and if any of you have the time, I would encourage you to read through the summary of this. It really placed a big emphasis on the role of the movement disorder nurse, the MS nurse, the epilepsy nurse, and the previous epilepsy clinical care program really pushed on the role of the epilepsy nurse specialist. I think we've got a lot of good out of that. Generally, nurse specialists in all specialties are very important in terms of a couple of different areas. So education, like I have to say, as doctors, we're not great at educating patients. We're doing the medical side, and we often forget about dealing with the day-to-day practicalities, which make life more livable. And that's where a nurse specialist has a huge role there. Not only just in terms of educating patients, but also other healthcare staff, family members. How do you manage the relapse? What do you do if someone has a seizure? Things like this. Patient support and advocacy. We can't overemphasize how important it is that someone has someone they can ring reliably and get a call back. They're great support for primary care, and they're great for the assessment and treatment of patients within their own scope of practice. So how neurology nurse specialists and advanced nurse practitioners can help us here? Well, we know that the neurology service here faces numerous challenges. Some of these are common to everyone. The waiting lists are pretty disastrous. Staffing levels aren't adequate by any international metric. Access to beds is practically non-existent. Access to diagnostics is dreadful. We're still shipping people 80 miles down the road to get EEGs. And some of those are very common. You get the same level of complaints from most services, but I think as the pandemic recedes, we've now got an opportunity to try and develop the service and change the model up a bit so that we're treating people more effectively and close to their own level of what they care. I think nurse specialists play a huge role in this, and there's a significant role they can play in this one. Avoiding admission, facilitating earlier discharge. This is a massive thing. Only just this morning, we've seen someone who almost certainly had an MS relapse, and yet this person is not coming anywhere near the door of an A&E because we have a nurse specialist they can ring, they get them into clinic, I see them, we see them, patients goes home again, lowest level of care, avoids the emergency department entirely. And that's one thing we can definitely help. Reducing waiting times for clinics. Nurse-led clinics are great in terms of stable follow-up patients not needing to review. They're fantastic. It frees up consultant time, NCHD time. It allows us to get at the newer patients and move things on that way. Supporting patients. Having someone you can ring up on a reliable basis and get a phone call back in the same day is fantastic. Having someone who can take the fear out of the situation and say, okay, here's what happens when you have an MS relapse. Here's what we're going to do with this. Here's what you can do about it. Counseling patients, counseling families, telling them that having epilepsy is not the end of the world. How do you take your Parkinson's medications? Here's the helpful hints and tips that help that way. Supporting GPs. GPs, how my GP colleagues haven't shot me in self-defense at this stage, I actually don't know. Because by the time I finally get back the phone call they made, either the problem has sorted itself or they've sorted it. And having someone they can get back to more quickly, more reliably, it gives a better, more flexible, more available service. It's better for GPs, better for patients. It improves patient outcomes. Patients who have access to an MS nurse are shown in studies to be more satisfied, better medication management, and they just feel much more supported generally. And if you want to get very high level about it, it supports the aims of all the clinical programs that are out there. The specialist is well emphasized on all these, and it supports the aims of Sláinte care reform by trying to keep patients out of hospital, bridge that primary and secondary care gap, keep them at the lowest level of care they need with the best possible support that can work very well for them. Now, what do we need in the Southeast region in terms of nuts and bolts, the sheer bare bones of it? Well, based on the Joint Epilepsy Council for the UK and Ireland, they recommended one whole-time epilepsy nurse specialist per 100,000 population. That means realistically that's 3 to 5 full-time posts just for epilepsy nurse specialists. MS nurse specialists, we've gone with the MS Trust recommendations in the UK. They were previously accepted by NICE. Now, for those of you who don't know, NICE is the National Institute for Clinical Excellence, or in another way, the people who tell the NHS what they can prescribe. They state that there should be a maximum of 358 patients for a multiple sclerosis specialist nurse. Realistically, if we're going to do infusion treatments and develop the service properly here, that's probably at least 2 full-time equivalents to try and make sure we get that. Headache nurse specialists, it's actually difficult to obtain evidence-based recommendations based on the need for nurse-led clinics, which is a program that they've actually developed as a Sláinte care initiative in Beaumont Hospital, Galway, and a few other places. It's not unreasonable to see we need at least 1 or 2 of these in the Southeast region as well, just to try and get this going. And movement disorder nurse specialists. We've no specialist movement disorder nurse anywhere attached to the neurology service. This is a massive limitation for people with Parkinson's and movement disorders, because again, you need someone who can give those hints. I mean, at least 1 or 2 of those. And you can't overestimate how helpful these people are in themselves. So I suppose as a take-home message as a conclusion, we know neurology services in the Southeast region are significantly understaffed. Now, some of that is probably in terms of kind of where we're at, some of the difficulty retaining staff, but it's an ongoing issue in itself that way. We don't need to browbeat ourselves in terms of get consultants in. We're getting consultant posts in. Now we need the extra people on the ground who can translate that into better patient outcomes. And that's where I think the development of neurology and our specialist role in this region will have a huge potential to improve patient outcomes that way. It's not an exaggeration to say that we need at least 6 such roles in UHW in different subspeciality areas of neurology. Indeed, if you look at population basis and most internationally accepted figures, you could push for far more than that. But we'll take whatever we can get, let's say the least of it. And I suppose those resisting, we look forward to any help you can give in helping us to bring this about. On that, I'd just like to say thanks for your attention. And I'll pass over to the next speaker, as they say.
Dr. O'Connor, thank you so much for that overview of the neurology services in Waterford. And as you say, you know, you have so many issues and gaps and deficits, but you very clearly outlined the difference that having at least neurology nurses in place would make, the difference in preventing admissions and making sure that your GP colleagues are still talking to you. I think at the end of the day was one of the things that you said. And certainly I think it's clear from what you're saying that you know, you stand over the numbers that we've come up with within the NAI campaign, as does the neurology clinical program and the neurology model of care. And I suppose for our next speaker this morning, I want to translate that the facts and figures and the numbers there into what that actually means for people with neurological conditions living in the Southeast. So Valerie, if I could hand over to you just to talk about your own experiences and the difference having access to a nurse would make.
Hello there, my name is Valerie O'Shea, and at the age of 30, 25 years ago, I was diagnosed with multiple sclerosis. So if you can picture the scene, I had a 3-week-old baby girl, and my first incident with multiple sclerosis was when I lost my sight completely in my right eye and partially in my left. So with a newborn baby and that to negotiate, really traveling to Dublin to see a neurologist was the last thing on my mind. We went on to have 2 more children. And in the 25 years that I am diagnosed, I have experienced various problems like weakness in the left side of my body, down my arm and down my leg, serious problems with balance, complete loss of balance, along with eyesight problems, and the general fatigue that goes along with negotiating multiple sclerosis on a daily basis. Now, like Dr. O'Connor was saying there, in my time as a patient and a service user with multiple sclerosis, I have seen a lot of changes in medications and a lot of changes in the service that is provided for me. The biggest change that I have seen in the time is under Dr. Orla Hardiman, Professor Orla Hardiman, a number of years ago in Dublin, was in Beaumont Hospital, was introduced some MS specialist nurses. And what those nurses did for me was, now instead of having to look for an appointment to see my neurologist if a problem arises, the first thing would be that even as a private patient, I would be waiting 3 months to see my neurologist. I just can't imagine what it's like to be a public patient and to be waiting 18 months, like Mags was saying there. There are more than 8,600 people who are waiting more than 18 months. Can you imagine with sight loss to wait that long to see a neurologist? But I would wait, in the past, I would wait 3 months to see my neurologist. And then I would have the difficulty of having to negotiate my way by public transport to Beaumont Hospital in order to see my neurologist, to put a question to them that can be answered over the phone and solved straight away. So when the MS speciality nurses were introduced into Beaumont Hospital, it really did change my life, because I know these nurses by their first name. I know the hours they work, and I can pick up the phone at any time and I can leave them a message and they will get back to me within the next 2 days. And a simple problem can be resolved in a very simple manner, rather than waiting 3 months or, heaven forbid, 18 months to present with a neurologist in order to have a small problem sorted. A small problem in that time has become a big problem and a compounding problem, and lots of other problems have happened in the meantime. So that's the biggest difference that it has made to me. As well as that, what it means to the medical service is that I am now kept out of a doctor's surgery. I don't present to my doctor if I've got a problem, because my doctor may not even know the answer that an MS speciality nurse would know the answer to. He would have to go and find out that answer. And that's taking up time in the surgery and time in the practice. The other thing is that it keeps me out of the neurologist's office and spares up that time for people who really need to see Professor Orla Hardiman. A simple question, a simple solution doesn't need for me to present myself in her office if I can get the answers somewhere else. It also keeps me off the waiting lists. Look at the 8,600 people who are waiting. It keeps me off that list. Hugely, personally, for me, it reduces my stress level. If I know that I'm experiencing a problem and I know that there is something I can do about that immediately, I don't have to go through getting an appointment, traveling to Dublin to see a neurologist, waiting for the outcome, hoping that the problem is solved. It's such a relief to me to know that any problem I might encounter, I can run it by somebody who is a specialist very, very fast and get an answer so quickly. Now, even if my MS nurse doesn't know the answer, she has the ear of my neurologist. So she can directly liaise with my neurologist and come back to me in time and spare me all of that personal stress and strain of negotiating having to get to Dublin. Not having to travel, not having to wait for an answer, being able to get an answer very, very soon, a top class answer very, very soon. And also what I really love about my MS speciality nurse is that there is a personal relationship there, in the sense that I know her by her first name. She knows me by my name. She knows my situation. She can picture where I live and the kind of life that I live. She has built up a picture of me as a person and how I expect to live my life, and the dedication that I'm willing to give and the work that I'm willing to put into having my medications right and having my lifestyle right. So she's on my side in a very, very personal way. And she's a total expert in the MS field, in the sense that she has time to look up the latest research that's being done. She, you know, if I hear about something in the newspaper, she has probably heard about this a year ago. So I can ring her and say, you know, I hear about, you know, new connections with the Epstein-Barr virus. What do you think about that? And she's already studied it and she has something to say about it. But again, if I had to discuss that with Orla Hardyman, I just wouldn't, because we don't have time in our neurology appointments to discuss these things. So I get more of a, she's my liaison with what's happening professionally and academically and medically with my condition. And I feel so much more empowered for having her there. So that's really all I have to say. That's the difference that has happened to me in the last few years. I've seen a lot of changes, but by far the biggest change in my treatment has been the availability of an MS specialty nurse and the reduction in stress that has happened in my life. I understand now more about my illness. I understand that there's a stepping stone there, that if I want to check anything out, and my MS nurse might say to me, look, you really need to go to see a neurologist about this. That would be maybe 1 every 10 phone calls. She would say to me, look, you know, you need to see a neurologist about this, but for everything else, let's try this, let's try this, let's try this. And if those things don't work, then you go to your neurologist. And I go to my neurologist with a record of what I've done. So it saves her time, it saves me time. And it certainly has enhanced my life and my journey with multiple sclerosis.
Thank you so much, Valerie. I think that's just a fantastic insight into the role of the neurology nurse in your life and in managing your condition. And I'm just thinking 2 things. One, when you're saying 1 in 10 of the calls that you have with your nurse, she might recommend that you speak directly to your neurologist. That's 9 queries, you know, that you're directly saving time with the neurologist there by having the neurology nurse one-to-one. The other thing I'm thinking of is when you're saying that you have this one-to-one relationship with the nurse where she knows your name, she knows details about your lifestyle, your medication management, and just how unsustainable having one neurology nurse for Waterford is going to be in that context of how one person could hope to provide that level of service that's needed, that level of one-to-one service with the catchment area of 500,000, as Dr. O'Connor has talked about. I just want, so thank you so much, Valerie, for that personal insight. I just want to call on Maura Hayes, the neurology nurse now, to say a few words just about her role in that context of the one neurology nurse in Waterford University Hospital.
Thanks, Mags. Can you hear me? Sound is good. Okay, thanks for that. It's actually great to hear both sides from a medical perspective from Dr. O'Connor and Valerie's take on the clinical nurse specialist role. And you'll probably put it better than I can, Valerie. But I suppose just to say, I started here in Waterford in September. I came having previously been a neurology nurse specialist in Kerry in the private sector. So it was definitely new to me starting in the HSE, but to be involved in a bigger organization and a bigger hospital as well with more than one neurologist would have been new to me. I suppose my brief, and I was interviewed to be a clinical nurse specialist in neurology, and my initial focus was to concentrate on 10 conditions. To name but a few: epilepsy, headache, multiple sclerosis, motor neuron disease, Parkinson's disease, dementia, muscular dystrophy, and stroke. So the remit is huge to start with before knowing any numbers. I suppose after talking with Dr. O'Connor and Dr. Crowley, we agreed on a plan of action to hit the ground running with regards to my role and what was perceived to be the deficit. That being said, from an inpatient, outpatient perspective already, and from consult level that Dr. O'Connor spoke about, if I am to be the signpost for all of those conditions, and that's a starting point, I'm going to be on the phone all day, just blocking queries and doing no actual work. I suppose we've decided what the deficit was initially and what patient cohort I'm to concentrate on. That being said, while I have that discussion with the consultants, the hospital may have different views for me, and I find I have to be very definite in the cohort and what I can do and achieve short term. So I suppose, as Valerie says, if I'm often the person most visible post-diagnosis to a service, and if I'm to carry out my role to the full and be the educator, the advocate, the referral onto a multidisciplinary team, the setting up of multidisciplinary team, and seeing as this role is new in Waterford, and the fact that there was nothing there apart from the consultant neurologist to start with, I'm finding already that this role is going to be unsustainable. So therefore, we're deciding the cohort initially to start with and trying to set up a service as best we can. With MS, it will be the setting up of infusions, the trying to, from today, should a person be diagnosed with MS, that we'll be able to look after their care in this geographical area, rather than should their MS be require more efficacious treatments. In the past, they would have had to go to another treatment center. We would hope that we will be able to manage that here now by having my role and offer patients who want to be treated here that they should be allowed to do so. The other side of it is there are patients, for example, that have gone to other centers, and because neurology nurses are such a small number, we all know each other very well. So I'm aware of how many patients are currently their treatment being overseen by, for example, St. Vincent's, that they have 67 infusions that should be in our geographical area. Cork, obviously, are also, so those patients are traveling for treatments that we feel should be in Waterford. Why can't we look after the patients here now? But we need to allow me to set it up, to have more staff, more nurses, infusion nurses. And that's only one condition, that's only MS. Moving on to Parkinson's, who already have a deficit, as Dr. O'Connor said, of 80% of them have no interaction with a nurse specialist. But we know chronic disease patients function better when they have someone that they can call, when they have advice and they're educated about how best to take their medications, when they become ineffective, what other medication to go on. And the same with other chronic disease, medical neurology conditions. So I suppose it's just a brief overview, but for me and for us to be able to sustain this, as Dr. O'Connor said, there needs to be more nurse specialists. Neurology itself isn't a nurse specialist role. That needs to be subdivided down into the biggest cohorts from that 10 plus conditions that were mentioned in my job spec.
Thank you, Maura. Thank you so much for that insight. And I think you've given a very good comprehensive overview that you're doing your utmost. You have such an interest and commitment to this role. You have such expertise from your previous work. and you are, I suppose, doing your best with the situation that you're in, but really saying, look, we could do better. We could provide a better service to the patients in our care, just if we had more neurology nurses. You're not asking for anything that, as I say, Dr. O'Connor said earlier, the battle has been fought and won in every clinical specialty in Ireland, that the nurse specialist is critical to the management of chronic disease. And it should be no different for neurology. The nurse specialist is critical to an effective neurology service. And we would call on people this morning to as I say, visit the Patients Deserve Better website, www.patientsdeservebetter.ie, to highlight to their local elected representatives just how strongly they feel about this, how important neurology nurses are to the effective running of neurology services all over the country, and particularly in Waterford. I just want to call on Tony Wilkinson, a person living with Parkinson's. He's just going to talk briefly about his role. I say we launched in Cork in November with this campaign, and he's had a very hands-on role since in keeping in touch with the local TDs there. And I just asked him to join the launch this morning just to say a few words about that. Just, I suppose, to give an idea to some of the organisations, some of the NAI member organisations participating in the call today, and also local people like Valerie, of things that you can do yourself to support the Patients Deserve Better campaign in the Southeast. So Tony, if I could move to you there, just there briefly.
Okay, thank you very much, Mags. And thank you to Dr. O'Connor, Valerie and Marie. And what you've just basically heard there is the trident that works in the neurological group. Dr. Connor, the patient, the specialist nurse, the three of them working together. And that's the most important aspect of it. Dr. O'Connor getting help from the specialist nurse getting information from the patient, and it goes the other way round. It really is an important situation. And in Cork, when Mags came along, our group made a conscious decision that we would really push and follow this. And other groups like the Huntington's, the stroke, etc., all came along as well. And we put up a very good campaign, spoken on the local radio about the campaign Patients Deserve Better, got huge amounts of print column inches in the local papers, and that's in all the different areas within Cork. It's a huge area. And again, going to the hashtag Patients Deserve Better and filling in that and getting that information to the TDs. One TD rang me up and said, whoa, crikey, what's happening? Tony, what have you done? I've got over 100 already emails. That's important because one email is the equivalent of, say, 10, because one person sending is effectively 10 people. So that's a good figure. The other thing that we then did was individually, as a group and myself, I found TDs that were talking to us and everything. I gave them further information. I then looked at the hospital, and we were lucky in having Dr. Suzanne Timmins. You probably know her. And Dr. Timmins was involved in a mapping project for Parkinson's for the whole of Ireland. So I was able to go to her and to pull out just the relevant information for Cork that I could then send on to the TDs. So if you too can do that, pull out the information for your area and get that to your TD, and then keep in contact with them. We got such a strong response from the TDs that we actually went and booked a room at Boswell Hotel straight across from the Doyle. And I then had the support of one of your colleagues, John Smith, who came along and supported me, and we did a presentation with the TDs. And what we did was we also got all the local groups, the Huntington's, the epilepsy group, MS, etc., to come in on a Zoom call. So I was there standing, talking to the TDs, and they could see up to my left all of the other groups. So it wasn't just one person there, it was a group, you know, and that was the huge and important thing. And again, it's keeping that momentum going. Every TD that has replied to me personally, I have sent them forward further information. And I am having a meeting on the 1st of February, a Tuesday. Apparently it's a very good day to do it, in the evening on Zoom with all the Cork TDs. So that is some of the work that we've done. Again, if any of you want, by all means, through Mags, do contact me. If you want to have a little bit of advice about something, I'm more than happy to help. So that's everything there. Thank you.
Thank you so much, Tony. And I suppose it's just an example of how people can be engaged and involved with the campaign on the ground. I would like to thank all our speakers this morning. And to say, just to say, if people want to become involved, want to support the campaign, visit the website www.patientsdeservebetter.ie. We won't be going away after today. We're spending the entire month of January. We have been and will do, continuing after the launch today, campaigning locally with the elected representatives in Waterford, doing local media. I'm talking to local radio later on this evening and tomorrow in relation to the campaign. So please support it. We're going around the country with these launches. We'll be going to Sligo in February and Dublin later in February, and then coming back around nationwide in April, reiterating the messages of the campaign. So we will be back to each and every TD around the country, including in Waterford, in April, to see how they've supported this campaign and to reiterate the campaign messages. So again, I'd like to thank all our speakers this morning, Dr. O'Connor, Valerie, Maura Hayes and Tony for coming on board, giving their insights into the service in the Southeast and supporting your campaign. So thank you very much to all our speakers and to the audience today.